Peace and light. My name is Dr. Sonia Fulgham, a clinical counseling psychologist who is currently pursuing a master's in pharmacology. Today, I am inviting you to a discussion concerning the risk factors for Torsade de Pointe. Before looking at the risk factors, let us disambiguate what Torsade de Pointe really is. For the purpose of this presentation, Torsade de Pointe shall be referred to as TDP. TDP is a polymorphic ventricular tachycardia in patients that have a prolonged QT interval. The QT interval is the interval seen in the electrocardiogram, EKG, or ECG test of the heart function. The term Torsade de Pointe was coined in 1966 by Torsade. It literally translates to twisting of the points. TDP is normally preceded by several ECG warning signs. These include notable QT prolongations, short, long intervals, premature ventricular contractions, and since TDP could manifest as sudden cardiac death or synapse, its incidence is difficult to estimate. There are several risk factors for TDP in this presentation. We shall review them over the next couple of slides. Altogether, it is important to note that having just a single risk factor does not result in TDP. Typically, multiple factors must be present concurrently. Let's review some of these risk factors for TDP. The QT interval is a non-invasive risk factor that can be measured easily. But what is the QT interval, or QTC, on the EKG or the ECG? The QT interval denotes the tone from the beginning of the ventricular depolarization to when repolarization ends. It is measured from the onset of the QRS complex. And how about QT prolongation? Prolonged QT intervals is defined as QTCs that exceed the 99th percentile. For postpubertal males, this translates to 470 milliseconds, while females is around 480 milliseconds. Any QTC in excess of 500 milliseconds is regarded as highly abnormal. Some standard 12-lead ECG algorithms consider QTC in excess of 440 milliseconds to be borderline QT prolongation, in spite of the fact that the value is normally surpassed by an estimated 10 to 20% of the population. Simply put, QT prolongation is the heart rate adjusted lengthening of the QT interval. In the image on the slide, prolonged QT intervals is evident in the distorted TU complex. Arrhythmia initiates following a short-long short cycle sequence by a PVC, which then which means kind of warming up event that is characterized by the R cycle that exceeds subsequent cycles in lengths. After this, an abrupt QRS morphology switch happens from complexes that are predominantly positive to predominantly negative as denoted by the asterisk in the image. QT prolongation is a risk factor for TDP in the sense that QT intervals have marked effect of increased SCD risks, even in patients who do not have recognized long QT syndrome, LQTS. It is important to note, however, that there is no QT intervals QTC threshold at which TDP is known to definitely occur. Electrolyte imbalances are a known risk factor for TDP. Electrolyte imbalances can aggravate the increased risk of ventricular arrhythmia. Disorders associated with electrolyte imbalances include hypokalemia, which is potassium deficiency within the bloodstream. Is suspected to trigger QT prolongation through the modification of the rapid delayed rectifier channel in a way that leads to heterogeneity and dispersion of repolarization. The repletion of potassium has also been shown to enhance repolarization in the acquired or congenital QT prolongation setting. Hypomagnesium is another electrolyte imbalance disorder that is associated with QT prolongation. It refers to magnesium deficiency within the bloodstream. Hypocalcemia, or the deficiency of calcium in the bloodstream, has also been shown to prolong QT intervals, although in rarer cases than hypokalemia and hypomagnesium. Of the three, hypokalemia is the most important risk factor for TDP. Some heart conditions have also been shown to put individuals at risk for TDP. These include the following. Low ejection fraction. Ejection fraction refers to volumetric fraction of the fluid that is injected from a chamber at every contraction. It is a measurement that is expressed in the form of percentage of the amount of blood that the left ventricle pumps out at every contraction. Also known as EF, injection fraction is a terminology that is used in describing the ejection fraction if it is less than 55%. In other words, low EF means that less than 55% of the amount of blood within the left ventricle is pushed out with each heartbeat. Bradycardia. Simply put, bradycardia refers to an abnormal slow heart action or heart rate that is slower than expected. In general, slow heart action or heart rate is less than 60 heartbeats per minute. Bradycardia is amongst the major factors that predispose one to TDP. The inverse relationship between repolarization time and heart rate is primarily responsible for QT prolongation that is induced by bradycardia. Left ventricle hypertrophy, abbreviated as LVH. Left ventral hypertrophy is a terminology for a thickening left pumping chamber of the heart that may have flawed pumping efficiency. LVH can result from problems that overwork the heart muscles, that high blood pressure, and aortic stenosis. LVH has been shown to amplify and prolong the QT intervals, thereby predisposing one to TDP. Heart failure. The connection between heart failure and TDP rests in the electric and structural remodeling within which in turn impairs repolarization reserve. Sex and age has been implicated as risk factors for TDP. In the case of sex, evidence gathered over the years have shown that female sex is also a TDP risk factor. For instance, females have a TDP frequency of between 2 and 3 times more than males. The comparative frequency is especially higher post-puberty. This difference has, at instances, been linked to the hormonal variations between males and females. This hormonal variation is mainly linked to the effects that sex hormones have on the handling of calcium in general. Further, estradiol has the potential to elevate the propensity for triggering activity on the one hand, and on the other hand, progesterone and testosterone may reduce the propensity for triggering activity. However, the role that estrogen plays as contributing factor to the disproportionate TDP risk in women is still unclear. Old age, and particularly 65 years of age, has also been linked as a TDP risk factor. Age becomes more pronounced as a risk factor, especially in the case of drug-induced QTc prolongation for individuals with an underlying heart disease. Some drugs also tend to predispose people towards TDP. For example, the prorhythmic effects caused by antiarrhythmic agents that have strong blocking effects of LK. Such agents are considered risk factors for TDP. Non-cardiac medications that have relative modest repolarization effects have been shown to predispose people to TDP. Notably, some agents like amiodarone evidently triggered QT interval prolongation, although they lead to TDP infrequently. Some drugs that were associated with QTc prolongation and or predisposing to TDP have since been removed from the U.S. market. Some of those drugs include lipid-controlled drug Probocol and the antibiotic grapafloxacin. Consensus-based lists of drugs implicated in TDP predisposition have been published at qtdrugs.org. Firstly, extensive evidence shows that SSRIs may have some benefits for patients who have been diagnosed with constipation, predominantly irritable bowel syndrome. For example, fluoxetine has been reported to be an effective remedy in this regard. Thus, prescriptions of SSRIs to such patients is recommended, although this should not imply foregoing notable gastrointestinal adverse reactions and pre-existing conditions. Secondly, and on the other hand, it is recommended that TCAs are administered to patients who have been diagnosed with irritable bowel syndrome, which is characterized by predominant diarrhea. This is because evidence shows the prevalent prescription of TCA with registered effectiveness to IBS patients with abnormal spasms and diarrhea. So, in conclusion, TDP is a polymorphic ventricular tachycardia.